Welcome to Scrubbed In and Speaking Out, the podcast from the Registered Nurses Union, Newfoundland and Labrador, where we dive into the issues facing nurses and the advocacy shaping the future of public healthcare in our province. I'm Dan Williams, Digital Communications Coordinator with the RNU, and I'm joined once again by our President, Yvette Coffey.
Hi, Dan, and welcome everyone.
So today we want to talk a little bit about safe staffing, and obviously that's a subject that affects every nurse and every patient across Newfoundland and Labrador. And I want to talk a little bit, I guess, where we need to start is the core staffing review, which has finally now begun, we think. What we know is a contract has been awarded, a firm has been hired, and as we understand it, the preliminary work has already begun. Mm-hmm. So Yvette, I'm just wondering if you can start out by giving us an update on that process, maybe a little bit of the history of this core staffing review, how long we've been waiting for it, and of course, explain why this review is such an important step forward with regards to safe staffing for our nurses and, of course, for our public healthcare system.
So the core staffing review was negotiated by the Registered Nurses Union in 2019. So we are almost 7 years waiting for this core staffing review to get done. And what we talk about when we talk about a core staffing review, for 40 plus years, so decades, we have been staffing our hospitals, our long-term care facilities, our community care settings based on the patients and how they were 40 years ago. So an example of that, I had a knee surgery, a reconstructive knee surgery back in 1992. I was in hospital for 2 weeks. Mm-hmm. So I basically rehabbed and started my rehab in hospital. By the end of my 2 week stay, I was able to do all my own care. I was able to get up, walk around by myself with the crutches, do whatever. Today, that is an outpatient procedure. Gallbladder surgery, now an outpatient. Today, if a woman has both her breasts removed, a mastectomy, a bilateral mastectomy, that's outpatient surgery. So these patients that we have in hospitals or in long-term care facilities or being seen in the community because they're now outpatient are sicker. They are more complex with their care needs, but we have not changed our staffing model. We are still staffing hospitals for patients that, you know, you'd go in and this morning you might have 3 post-surgery patients today or 3 really sick patients, and the other 2 or 3 or 4 or 5 or however many patients they're giving you are basically somewhere on the way to recovery and going home. But today, everybody is like that fresh post-surgery patient or fresh admission that is really sick with their sugars out of control. Therefore, now they're having surgery for to remove a foot or their vision has been impacted because their diabetes has not been under control. So the patients that we're seeing today, we need to change our staffing complement. We need more nursing personnel, not less. So the core staffing review is started. Deloitte was awarded the contract by the government of Newfoundland and Labrador. And there has already been an email sent out to all of the employees of Newfoundland and Labrador Health Services to alert them that the units that are selected under 6 sites, that they will be coming to them to talk to the front line. We're sharing information that they will be doing a survey with all those frontline staff in that area. The core staffing review will not just be based on the patients. It will also be based on what resources do you have? Do you have personnel for lab? Do you have environmental services? Do you have clerical support? Or is everything that has to be done on a patient's chart got to be done by the nursing personnel? Do you have a nurse practitioner or a physician covering those patients? Or are you having to do virtual care for those patients, which means you need more nursing support to be with the patient while they're talking to their healthcare provider. There's a whole lot of things, what is the distance between your site and the next tertiary care site? Or hub and spoke as to how they call it in the health court. So if you're in Twillingate, how far away are you from Gander or Grand Falls to that site that you can send a patient? And what are the supports for travel, for getting the patient out of your facility? If you're in community care, do you have someone to call if your patient needs a medication change, if they have a wound that needs to have an order written to change the care? So the list goes on and on. So all of this is going to be taken into consideration. And this is the basis of where we start when we talk about safe staffing. So that's it for core staffing review. It's a lot.
Yeah.
And the areas that are involved, I should say, we decided we needed to do a rural area, a rural site that had long-term care, acute care beds, and emergency, and a community setting. So Placentia Healthcare Center in Lyons Manor, the long-term care facility, have been chosen as that rural site. Fort Howe in Labrador has been chosen. Gander, James Payton Memorial Hospital, the entire hospital will be our acute care one. The new long-term care facility, which has rehab and restorative care beds in Cornerbrook. And then here in St. John's, we are doing community health. And the community health site in St. John's is what's called Mount Pearl Square. And that has the whole basket of services in for community health, and also doing acute care units at the Health Science. So it'll be the general surgery burn unit at the Health Science, 4 North B, and 4 North A, which is the oncology medicine unit at the Health Science. So our cancer chemotherapy patients and that. Hematological disorders. So they're the 6 sites, and we are looking forward to having those conversations, and we're encouraging all our members at those sites to please participate. This is our chance to reshape nursing and healthcare in Newfoundland and Labrador.
So the main point, obviously, is getting accurate data, which we don't have. And I think that brings us to something else, because we often, and we've heard a lot of stories about people working short-staffed. And me, as someone who's not a nurse and is still learning every day, I always took that to mean they had vacancies. But they can be not necessarily, right? Because we're working with 40-year-old data. So they could be short-staffed and not have vacancies.
Exactly.
Yeah.
And actually, once we get our core staffing review done, once we get that, the sweet number of, it's not just registered nurses and nurse practitioners. Even though we negotiated this, this is actually going to impact licensed practical nurses and personal care attendants. So it's looking at that whole scope of care for the patient, nursing care for the patient. And once we get that right, we still have to adjust our staffing then, based on complexities of the patients.
Right.
So if you have someone really, really sick, you need extra staff, you need it now. So there's a whole lot that will go into this. There's so many things that impact safe staffing. The use of agency nurses, even the use of our travel locum. So if we don't have continuity of care for patients, that impacts patient safety. When we were talking about getting ready for this podcast, I used the example of when my mom was in long-term care. And I asked for a medication review because I noticed, her weight had dropped off. And my mom had Alzheimer's. So her weight had dropped off. She was having falls. And I was like, okay, I think it's time for us to revisit her medication dosages. And I had to ask for that. If we had continuity of care and primary health care, so a continuous primary health care provider, the same staff being responsible for reviewing the file, the chart, I think we would have, I know, we would have patients with less falls, and we've already proven in long-term care with the addition of nurse practitioners, actually. We've seen less wounds. We've seen less frailty and less falls in the elderly in long-term care settings. So I do think continuity of care, having the same people there all the time is a big thing. And also, we need in-person assessments. Virtual care is a stopgap measure, but it is not the gold standard of care. The gold standard is for me to be able to be here to visually and physically assess you myself, head to toe assessment, instead of depending on someone else to tell me all of that. So there's a whole lot that goes into safe staffing, but I think our primary start is to get that staffing review done, and we go from there.
We say sometimes, as someone myself who doesn't have access to primary care, we say, well, virtual care is better than nothing. Mm-hmm. But of course, that's not the bar by which we want to measure our healthcare system either, right?
Absolutely.
So access to primary care, so much of our healthcare system is dependent upon that, because if people don't have access to primary care, that's when things get missed. And if there's no continuity of care, like you're making, the point you're making is that what happens, right? Things get missed. They end up in emergency with multiple health problems, instead of just having one treated.
Well, they end up with preventable problems.
Yeah, things that could have been prevented had they had access to
Had they had access and continuity of care. Absolutely.
You also talked about the network of health professionals. And that's another thing that my eyes were open to when we were doing the President's Tour, is we heard about RNs having to cover because they don't have enough LPNs, or they don't have enough PCAs, or they don't know when the ambulance is going to show up, or there's no warning. So I guess we just make sure that people understand that core staffing review is not just about registered nurses, but it's also about the whole network of health professionals in our system, in our public healthcare system. And only until we get that data can we start putting all the pieces together, I guess, right?
Well, there's been recent news stories around, and I know NAPE has been out talking about the shortage of phlebotomists. So that's personnel who go around and they do your blood work from the lab, right? Yeah. So when these healthcare professionals are not there, guess who that work falls back to? When the social worker or the physiotherapist is not there, guess who that work falls back to? Everything falls back to nursing at some point. If you have multiple admissions and you don't have a ward clerk to do the clerical work, to do the admission papers and get their chart together, guess who's doing that? The registered nurse, the licensed practical nurse, the personal care attendant. So it impacts care of patients. And, I hate to say it, but all I'm hearing today lately is budget, and staying within budget. And, well, that's our core staff and that's it. We're not going above it. You're going to have to make a really strong case for us to call in somebody. If you have a healthcare professional, a registered nurse, a licensed practical nurse telling you, we need extra staff, you need extra staff. Budget should not come into the equation when we are talking about the safety of not only our patients, but also our employees, the people who are working there in the system. And from an injury perspective and preventing injuries, if you do not have the right number of people, the right complement of people there, you are putting staff at risk, which then puts patients at risk.
We started this conversation talking about core staffing, and you brought the example up of when you had surgery. Once upon a time, you were in the hospital for 2 weeks. And maybe it's also important for us to recognize that, of course, we have 40-year-old data, that where do the outpatients go when they get released? Now, who's caring for them, right, in community?
Well, our community health nurses, We call them the poor cousins of healthcare. They do not have access to overtime, the same as their counterparts in long-term care and the acute care settings in the hospitals. They do what they call flex, and you've heard me talk about that. So they'll go in and work for 4 hours, probably in the morning, or they'll work till 6 p.m. and then have to come back in the nighttime to go out and to put in intravenous in someone, to give someone an antibiotic through their intravenous home. To go out and do what's called a chemotherapy disconnect. So some patients go home and actually have their chemotherapy hooked up, and then our community health nurses disconnected. Wound care management. All of these patients, I heard my colleagues in community health talk about some of the patients and some of the things that they're having to do out in community that me, as a critical care nurse for 25 years, I was looking after that type of patient in ICU 20 years ago. Not alone say 5 years ago, 20 years ago versus 40 years ago. But 20 years ago, I was looking after patients that are now out in the community being looked after. We have not increased the resources in community health. We have not increased resources in public health. Our public health nurses, all the new vaccinations that we have come up when, it's not just COVID, but now we're having to revaccinate people for polio and diphtheria and whooping cough because the immunity has worn off. All of that workload has increased, but we have not increased public health resources. They're also expected, the prenatal, the push for breastfeeding, healthy babies, prenatal care for pregnant moms, but they're also involved with preschool assessments. The list goes on, but we have not adjusted course. We have not adjusted staffing.
So all of that to say, we're very excited to get the core staffing review finally off the ground and moving. And we have sent out communications to the sites that are involved, encouraging them that when they hear from employer that this is happening, to make sure they get involved and make sure they have their say.
And it's not just about their units, because all this data from these 6 sites will then be extrapolated to the rest of the healthcare throughout the province of Newfoundland and Labrador. So a community healthcare setting in Corner Brook, it may not have the same staffing as the community healthcare site in Mount Pearl Square in St. John's, but it will be based on the complexity of services that are being provided, and of course, the volume of services.
Of course, safe staffing is not just a conversation here in Newfoundland and Labrador. Across our country, we're seeing growing attention to nurse-patient ratios. We've seen in British Columbia and Nova Scotia, there's some ratio language now being incorporated into collective agreements. So I'm just curious if we're ready to even begin that conversation here in Newfoundland and Labrador to approach this issue.
Safe staffing, at the basis of all of this is having our core staffing complement right. That needs to be right. So that's where that starts. And then basing any kind of staffing and model. And when we talk about staffing model, it's not about numbers. It's about, for these type of patients, how many registered nurses do you need? How many licensed practical nurses do you need? How many personal care attendants do you need? And that is going to vary based on where you're to. Are you in a rural, remote area of Newfoundland and Labrador? Are you here in the middle of St. John's? Are you in the middle of Gander? Are you in the middle of Corner Brook? So all of that, when it comes to safe staffing, we start with that core staffing review. That's at a minimum, and we work from there. Now, you'll hear talk about, Newfoundland and Labrador Health Services has a staffing-based model scheduling system that it's supposed to be based on acuity, which means complexity of patients, and that they can adjust staffing based on that. And that would be good if that's the way it's working. But it's not working like that. Just this morning, I had texts from people telling me, so what they do is, you're short on this unit and you're short over there. So you're short 2, you're short 1. This one is short 1. So, but this one got an extra nurse, or they're at their core. Let's just say they have their core. Well, let's take from them so that we have everybody down 1.
So everyone's short.
Because budget-wise, we're not going to call any more staff. And we're seeing this. We have managers actually putting that on paper, saying we have to stay within our budget. So they're floating nurses all over throughout the acute care settings. And I'm hearing this everywhere. And we've been on the provincial tour. We're hearing it everywhere. Floating is not the answer. Floating, you're only just robbing Peter to pay Paul. What you need to do is add extra staff. So the more I hear about managers saying budget, we've been told to keep our budget in line, the more aggravated and irritated I get, because the safety of staff and the safety of patients should not have a price tag on it. Absolutely. So that's our start, is the core staffing review. And then it's listening to the front line. And when they say, we need more staff, we need more staff. But that doesn't mean you make your staff short to be short like mine. Just get me the staff.
Yeah. And I think that's a message that we need to keep pushing the employer. And of course, we need to let members know that we want them, we want their voices to be heard, but we need the employer to come to the table and listen to frontline.
Absolutely. That is number one. And when a professional looks at you and says, we're drowning, we need more staff, you need to get them more staff.
All right. Well, thanks, Yvette, for once again sharing those insights.
Thanks, Dan. And thank you, everyone, for listening. And don't forget, if you get an email saying that you are part of this core staffing review, please participate.
And thanks to everyone for tuning in to Scrubbed In and Speaking Out. Don't forget to follow or subscribe for more conversations about nursing and the advocacy shaping the future of public healthcare in Newfoundland and Labrador.